I'm a generalist, radiation oncologist. I work at a network site for WVU, and I have the privilege of going to whatever meetings that I'd like to attend. So this year was the first year that I was privileged to be able to attend ESTRO. It was an amazing time. It was in Glasgow, and I was also able to extend it to a few weeks afterwards to explore the country. So it's nice to be able to go to meetings and also work in the leisure time as well.
So what
Um,
you're saying then is we should make sure at some point we plan to go to Estro, correct?
That's what I'd say. I've already marked my calendar for Vienna next year, and I hope to be able to go as well.
All right. So I was following you on social media when you were at Estro. Can you tell me your top 5 abstracts from Estro? Let's start with number 5 and do like a countdown. Let me do a little bit of a drum roll. Number 5.
Oh gosh, how do I start with? I don't know if I can really put in order of importance because there's a few exciting studies. Um, but why don't we kind of just go with the order that were written down?
Okay. Number
So the
1.
number one, I
Number
like
1.
Narwhal. Narwhal 2 is really interesting. It was a dose escalation study for stage 2A to 3B non-small cell lung cancer, including 350 patients. And the reason why that we were looking at this, or rather, this study was looked at, was because there was homogeneous escalation to the overall PTV and RTOG 0617, which did 60 versus 74 gray respectively. We all know that the 60 gray arm won in that study. And so this study hypothesized it might be possible to differentially dose escalate the primary tumor versus the involved nodes, given that most failures are in the primary tumor location, perhaps that needs a little bit of a higher dose. And so essentially the study showed that there's improved local regional control if you do up to 95 gray and 33 fractions to the GTV primary and up to 74 gray and 33 fractions to the nodes. And their control arm was 66 gray, which is a little bit unique. In the United States, it's more so 60, but according to a study in their region of the world, 66 gray is standard of care. So those are the two comparison arms, 66 and 33 versus up to 95 gray for primary and 74 gray to nodes. And it did show that there was an improvement in local regional control.
Yeah, I find this study to be really exciting um, because I think that the challenge we have is trying to get high doses into the mediastinum. I don't know if that's really what we want to do. In the Pacific study, I think they had a lot of node negative patients in there. And if we can dose escalate the primary tumor, that may be better. If we can differentially dose escalate the primary tumor, that may be better than um, dose escalating everything, and then making sure we follow up with a year of the checkpoint inhibitor. So to me, this is a really exciting study. What was your second top study, Jeff? Should I do a drum
So
roll?
sure,
Number two,
I like the
two.
I like the ETOP chest study. It's a single arm phase 2, very ambitious study that for non-small cell lung carcinoma as well, including upfront SBRT with chemoimmunotherapy done simultaneously. So there was not a buy-in with 3 to 4 months of induction systemic to ensure no progression prior to receipt of SBRT. And I also love how there's metachronous treatment of the primary tumor. After 4 to 6 cycles of carboplatin, paclitaxel, and durvalumab, as long as there's no progression, then the primary tumor was treated. Now, I think a little under half of patients received treatment to the primary tumor, which is usually 3 or 4 months after the upfront SBRT to oligometastatic sites. It only allowed up to 3 sites of metastases, including 1 that had to be extracranial for SBRT. And so again, simultaneous consolidation of oligometastatic sites with SBRT and chemoimmunotherapy followed by restaging. The goal was really ambitious. It was a 1-year progression-free survival improvement from 25% to 50%. It was just shy of that. The 1-year intention to treat progression-free survival is 45%, just shy of the goal. Again, this was single arm as well. And so for me, kind of the take-home point is most patients are likely to progress, even if you do upfront systemic therapy with oligo SBRT consolidation upfront. So it's kind of practice confirming for me to continue to do kind of a litmus test of induction systemic therapy for these patients who are de novo oligometastatic, because all patients were staged with PET CT and MRI brain in this study. And so that's what I do, is a buy-in with a litmus test and then treat the primary and the oligometastatic sites. But there's an ongoing kind of subsequent aim of this trial or cohort where they're going to add on tremelimumab to durvalumab, and they're still doing upfront SBRT. So it'll be really exciting to see if systemic therapy intensification can help, because over half of these patients, about 2/3 develop new distant metastases. So that's kind of our main concern here, is distant metastases, but still encouraging results. I love the design of upfront SBRT with concurrent chemoimmunotherapy. That's the only study of which I'm aware that really investigates that. Gomez, Saber comment, they require that litmus test buy-in, which is what I'm doing in the real world, but it's exciting to see new data of different approaches.
I agree with you 100% right there. We need better ways to treat the oligomet population. All right, Jeff, number 3.
All right, the Start New Era study. So this is another non-small cell study. And so this included, it was based off of Pacific 6, which showed promising results for patients that received sequential chemo, followed by radiation, followed by consolidative durvalumab in a more frail population that were not candidates for concurrent chemoradiation. So this study did an optional neoadjuvant chemotherapy buy-in, kind of like Pacific 6, except for the radiation was SBRT only, VMAT over 5 fractions for central tumors and N2 burden. So it's a pretty ballsy study. Only 50 patients were enrolled. This was a phase 2. And basically a minimum of 35 gray was delivered in 5 fractions. That they separated out the dose to the primary tumor and the dose to the nodal disease, kind of similarly to NARLAL2, where the median prescribed dose was 45 and 5 to the primary tumor and 40 gray and 5 to the lymph nodes. Now, this runs into the same issue as NARLAL2 as well. On that study, 74 gray to the involved lymph nodes. Well, you can only do 70 gray to the esophagus to 1 cc on the NARLAL2 study, whereas you could do 74 gray to the mediastinal organs up to 1 cc. So they had to be more tight in the mediastinum. Same issue on Start New Era. Like the constraints are all less than 40 gray Dmax, ranging really, for heart, esophagus, whatever, from 35 to 38 gray. So if the average dose to nodes was 40 gray and 5 fractions, how did they do that with these constraints? That's what I'm a little bit, that's my question is, how, the proof is in the pudding. Like, how did they do this? It seems like, art, more so than science, if that's what your constraints are, lower than your mean dose to the actual nodes. But that being said, 5-year local failure after SBRT was only 38%. 5 fraction central tumors, like with N2 disease, this is potentially practice changing. It's only phase 2, so I'm looking forward to more data. But long story short, of course, there's more distant metastases, but the take-home point was it met safety and local control endpoints. Again, 5-year local failure just under 40%. Then there was no grade 3 plus acute or late toxicity. So I can't wait to dive into this a little bit more to find out how they delivered 40 gray to those lymph nodes. In fact, some patients received 45 gray to nodes as well. How do you do 45 gray and 5 fractions to N2 disease when all of your central structures are limited to 35 to 38 gray, basically Dmaxes?
Be very careful.
Yeah, I got to be very careful. Can't wait to see the full publication. And I mean, my goodness, think of how many patients that this might serve if unfit for chemoradiation. And if these results are really that good, I mean, goodness, it'd be really interesting to see, if perhaps this could be extrapolated to more fit patients. But of course, we're years and years away and phase 3 trials away from that concept. Yeah, 50% of the time, our first recurrences are in the pelvic lymph nodes after primary prostate treatment. And so there's kind of 2 different schools here, just involved nodal radiation, which is very often seen for SBRT with tight margins, versus, elective nodal radiation, kind of including the regional area at risk. So basically, with all these advanced imaging modalities, which is the best treatment? Elective nodal or INRT with SBRT? Interestingly, the day before this, there was a really heated debate on involved node versus extended nodal radiation in the recurrent setting after primary prostate treatment, whether radiation or surgery, at ESTRO 2024. And this was the day prior to Storm. Interestingly, SBRT won. Whereas at a different conference, urologists are asked, what should radiation oncologists do? ENRT or INRT, elective versus involved node. 95% of surgeons said elective nodal radiation. So who's right? The Conference of Radiation Oncologists or the urologists? And so this trial mandated ADT times 6 months. Majority of them were prior radical prostatectomy without radiation. And this comes into play later on because prostate bed radiation was advised but not mandatory if T3 or R1. Whereas the ADT was required for 6 months. So about a third of patients received prior radiation and postoperative radiation, and about 10% overall received prior definitive radiation, with some differences between the cohorts. So up to 5 lymph nodes were included. About 20% of these were staged with choline, and then about 80% of them were PSMA. And so most of them are single node, about 60% of them were just one node, and only 15% were 3 to 5 nodes. So the minimum follow-up was 2 years, so really, really good follow-up on this study. And essentially, there was improvements in biochemical regression-free survival at 3 years from 47 to 69%, and also radiological regression-free survival at 3 years from 70% to 90%. So that's elective nodal radiation was superior, but however, at what cost? There was worst two-year grade 2 plus GU toxicity was not statistically significant, but at any given time point, grade 2 plus GU toxicity was numerically worse with elective nodal radiation. And really the reason why is prostate bed radiation was delivered in more patients in the elective nodal radiation arm because about 63% got prior radical prostatectomy on the elective nodal arm, and 52% on the 30 and 3 involved node arm got prior radical prostatectomy. So 10% more patients on the elective nodal arm received no prior prostate bed radiation in the past, which is likely why it was recommended. And additionally, who's going to do SBRT to prostate beds, right? So it's just less common, essentially. And so more prostate bed radiation was delivered in the elective nodal arm, and that actually on subset analysis was driving the differences in grade 2 plus GU toxicity. So for me, what this becomes is in chart rounds, if I ever see involved nodal radiation without elective volumes, I'd say why not liberate the 20 to 25 gray isodose line? Because if it's a question of volumes, you can still do 5 fractions and use a 20 to 25 gray elective volume. This trial is not designed to ask that question. So the purist really in elective nodal 45 and 25 with SIBs to the involved lymph nodes is the true winner here, right? And of course, I'm talking about an imaginary, third arm where you use more liberal 5 fraction volumes to 20 to 25 gray. That's what I have been doing in my practice as I use these elective volumes. But we all know that for each disease site, there's conflicting data as to whether or not you just do tight SBRT around the node or add a little bit of an elective volume. I don't know if I'm going to change my practice based on this study. A lot of my patients can't make it for 5 to 6 weeks. I have anecdotally had really good results with 5 fraction SBRT with more elective volumes. I love how they did 6 months of ADT for these patients with a pre-salvage PSA around 1. I don't think ADT-free survival is the way to go, as shown by the STOMP trial from Pete before, and then also the Oriole trial that shows about 80% of people fail by 2 or 3 years if you don't use hormones. So all in all, I think this is a very valuable study. But I do question, what is the utility of potentially using an elective volume with SBRT, which this trial is not designed to ask. But regardless, fantastic study. Can't wait to read the full publication.
One of the things that's kind of interesting about this is before sport, I didn't know when to treat the lymph nodes and when just to treat the bed. Okay. And right around when sport came out, we were kind of figuring out when I was at Penn, how do we approach it? How do we integrate it into our practice? And it's kind of funny. I think that's right when the place where I was working got access to the PSMA PETs. And I had like 2 or 3 in a row of the patients where all I did was treat the bed come in with a rising PSA, and sure enough, all three, bing, bang, boom, had a pelvic lymph node recurrence. And, so that really teetered me into, or got me thinking that we really need to be treating more elective nodal up front when we see these patients, or treating the whole pelvic
Mhm.
field. It's kind of funny now that I'm here down at MUSC, their standard for some period of time has been to treat in a post-op setting the pelvic lymph nodes too, and
Mhm.
just as their price of admission, so to speak. And when I ask Dave why that is, he goes, well, the surgeons were the ones trying to tell him to teach, or the surgeons were the ones telling him to treat those lymph nodes. They dissected them. We should be treating them, because they weren't always sure if they're were cherry picking or dissecting, or their dissection was never proven to be therapeutic, only diagnostic. Um,
Mhm.
so it is funny how these studies and the technology guide what we're trying to do in our clinic. Um, and I think we're getting a lot better in treating prostate cancer after um, surgery, and I'm excited about it. There's still a lot of questions to answer, and but I
So many
also like the
questions. Yeah.
a lot of questions, but I also like how there's still some great radiation questions, and
Mhm.
looking at that flame with the integrated boost is going to be another great thing to try and figure out how to bring it into our practice. And here at MUSC, we've started having discussions about that.
Yeah, and to touch on nodes in Storm as well, did the PSA doubling time was 6 months or less in both arms, so that there is more aggressive. Pre-salvage PSA was 1 on the sport trial. Since you mentioned it, there was a post hoc analysis of potential benefit in nodal radiation, including ADT, for when PSA is greater than 0.34, if I recall correctly. All these are about 1.0, so they're above that post hoc threshold. And then, of course, there's that imaginary fourth arm on sport as well. What about whole pelvis without hormones? If your PSA is low enough, maybe that's reasonable. And then raves as well. Raves looked at no ADT in this setting, but their pre-salvage PSA was much lower than 1.0. So, it's kind of a mixed bag, right? When do we add nodes to prostate beds? And then when do we add ADT? I think it's difficult. My board's answer on both of those is if post prostatectomy PSA is greater than 0.2, I just add both on boards. But in the clinical, world, it's much different, and it varies from patient to patient about both of those questions, ADT or nodes.
This
So,
may
but
require a whole separate discussion.
exactly,
Maybe
yeah,
me, you, Nick, and a few others just kind of go through the data, so to speak. Another 5 questions.
right.
Okay. All right. You ready? Number 5. Well, number 5. Number 5.
Well, number 5 is kind of like a package deal, and of course, it's from David Palma. It's about Orator and Orator 2, which we should be pretty well versed in what these studies are. TORs, with radiation afterwards, and hopefully they don't need chemo radiation, right, for more lymph nodes or extracapsular extension, those kind of things. Always try to avoid. But really, what I want to focus on from his presentation, Orator and Orator 2, really was he made a very insightful post, right? Contrary to early non-randomized comparisons, TORS is not superior to radiation. So why were these studies wrong? And the quote is, patients with resectable disease have better outcomes, and you can't account for that without randomizing. So let's talk about this in head and neck, and then I kind of want to ask just an open-ended question about whether or not we have this data for a number of disease sites for radiation versus primary surgery, because we can't account for that patients with resectable disease have better outcomes and without randomizing, right? So are we able to randomize these patients? But let's just focus on Orator and Orator 2. In the immediate post-treatment period, the MDADI, the MD Anderson Dysphagia Index, swallowing scores with radiation were higher, but it was not significant for trial definition in 2012. But in 2016, they officially updated it to define 10 points, which was the same as the Orator estimates for being clinically meaningful, because it separates out aspirators versus non-aspirators at 9.5 points, tube fed versus non-tube fed at 10.8, And smaller differences are important to our patients. But over time, the end-daddy curves converge due to decline in the radiation arm, maybe late effects. Quality of life is similar at 5 years. A 10-year add-on study is in the pipeline. Of course, radiation and TORS have differing AE profiles. Key take home is to try to avoid trimodality therapy. And so his conclusion was, every patient with resectable oropharyngeal cancer should be seen by a surgeon and a radiation oncologist. But what if we replace oropharyngeal cancer with lung cancer, esophageal, rectal, liver primary tumors, liver metastases? Like, we don't have a lot of randomized evidence for organ preservation versus surgery across a lot of disease sites. So it really stuck with me, this quote: patients with resectable disease have better outcomes, and we cannot account for that without randomizing. So it's just really neat to hear that coming from Dr. Palma, who generated the prospective randomized evidence to be able to ask this question. And it appears that there's no benefit in quality of life when we do add surgery. So it's all about patient selection, right? And this, in the real world, I'm in a community practice associated with an academic hospital. Our surgeons tend to be a little aggressive, even with base of tongue. When I first started practicing about 4 years ago, there would be extracapsular extension cases on preoperative radiological imaging. Of course, radiological imaging can't really predict ECE, but I'm like, my goodness, I see at least 3 lymph nodes there, and it looks like there's ECE. Can we have a chat about, with a radiation oncologist and a surgeon before we put them down that surgery pathway? And recently I've seen that we're getting better in the last year about selecting for these patients for radiation. And so I just think it's fantastic that we have the randomized evidence to look at this. And it's funny how the early non-randomized comparison of TORS showed that the survival was clearly better with TORS than radiation. And then when we go into a randomized controlled trial, 100% of patients had no failures on orator 2. You can't really knock 100% success, right? So just kind of want to end on a controversial note and pose that question. Should all patients with resectable patients or all patients with resectable disease see a radiation oncologist and a surgeon? Controversial note there.
So I'm going to answer that in a slightly different fashion. I think this was one thing I remember Eli telling me. It was some surgeon up at Brown, last name was Katie, who always said biology is king, selection is queen, and the new technologies are the prince and princesses. And the prince and princesses are always going to try and overthrow the throne, but they never succeed. Rarely do they succeed. Almost never do they succeed. And I think, this is what you're seeing, one of these things kind of circle around time and time again. And my take on it is, I think we're getting closer. I still remember with the lung cancer when it was that SWOG study with Kathy Albanes, where they were doing pre-op chemo rads and then surgery or go to 60 gray. And, they liked operating on the ones who got a good response. And I always thought they need to operate on the ones who didn't get a good response, and the ones who are getting a good response, let them go to 60 gray and just, be done. I think, we're getting better. And you're always going to see these conflicts, because I struggle with the question of surgery versus radiation as versus the other, and my surgeons that I work with, I consider them colleagues, and we're trying to ask the best question. And we do it a lot in the oligomet, where they may operate on a few and I'll SBRT some others. But, I really think we need some type of biomarker, because to me, radiation is a drug. It's got a prescription with a dose and a frequency. Surgery, I think, can also be considered a therapy or a drug at times. But we need some marker that says this is something that's better with surgery. This is something that will respond to radiation. Maybe play the odds if there's cells somewhere in the background that we can't see. And so therefore something that's less invasive may be better. But, it needs to be an either or, not a versus type of question. Does that make sense? How maybe I'm getting old and senile. But
no, totally agreed. That just reminds me of another one of my favorite sessions that was, is there a decreasing role for radiation for non-small cell lung cancer, you know, in the neoadjuvant chemoimmunotherapy era? And basically 10 to 20% of patients who undergo neoadjuvant chemoimmuno from stage 2 to stage 3B with intention to undergo surgery, 10 to 20% of patients don't make it to surgery. So Drew Maganaki had a good, you know, I had a good conversation with him on this. Maybe the type of local therapy matters less. Maybe they just need to get a local therapy, because when we put these patients down the neoadjuvant chemoimmunotherapy pathway, 10 to 20% of them might not receive local therapy. Is that just bad biology? Do we need better biomarkers to identify those patients? Or would they still be better served potentially by upfront chemoradiation, where we know the vast majority of patients will complete it? Because as we know, you know, for patients with endobronchial disease, for example, if they obstruct and they collapse, sepsis and death is a risk of that, right? So it's almost like prophylactic radiation to help prevent central airway collapse. So like, is just receiving local therapy the most important thing and not necessarily the type of modality? And I think those are the questions that we should be asking is, you know, are these patients we're going down these neoadjuvant pathways, are they going to receive local therapy? And does it really matter what type it is? But yeah, same team for sure. That's the approach. Surgery versus radiation, I think I should take out of my vocabulary, because it
Yeah,
inherently
it needs to
the
be.
modalities against
Yeah,
one another.
yeah.
Yeah.
Hey, I appreciate your time. I found this very exciting today. Hope to see you more. Maybe we can do this more during the summer, or, you know, any other meetings coming up. I'm sure we could do it then. But I do appreciate taking the time to talk today. Is that okay?
Oh, definitely. And hopefully I'll see you in Vienna next year if you can swing it.
I got to get someone to watch my kids, man. That's my
Just
problem.
hire a babysitter on Craigslist. She'll be good.
All right, stay safe. Okay, take
Thanks, Brian.
care.
You too. All
Yep.
right. Bye.